Today, adults who are terminally sick in California can now choose to end their own lives. California is the fifth state in the nation to adopt a right to die law. The fight for it was largely led by Brittany Menard, a Bay Area woman with brain cancer who moved to Oregon 2 years ago to legally end her life.
Canada is now set to promote and expand access for their citizens to physician assisted suicide, following actually a Supreme Court decision there that sort of overturned the notion that it could be blocked.
A woman suffering from a debilitating disease has chosen to be among the first in our state to end her life under a new law that went into effect today.
Not to die. Passionate voices for and against assisted dying outside Parliament.
We want choice.
This is a question on which there is no middle ground.
Number 2 bill.
Modern Americans are guaranteed almost every right. They have the right to love and marry whomever, to freedom of speech, and of course, the right to equal treatment under the law. However, there is one thing that Americans do not have a right to: the right to die on their own terms. While some may disagree with this statement, arguing that a person can take their life at any moment, this does not change the fact that there is not a painless option for death. Due to the advancement of medical technology, dying has become an extremely long and painful process, as doctors now try to do everything possible to keep patients alive. While this is acceptable if it is in the patient's best interest to be kept alive, many suffering terminally ill patients wish there were an alternative. This is why many countries have legalized the method of physician-assisted suicide, otherwise known as PAS, which is a prescription that can be chosen by terminally ill patients as an end-of-life option. This prescription is taken at the time and place of the patient's choosing. Physician-assisted suicide should be legalized in the United States since it is the most humane method of death for the terminally ill that choose it. One of the main arguments against the legalization of physician-assisted suicide is its immorality. However, one would think it would be extremely immoral to keep a terminal patient suffering for long periods of time when there is a painless alternative. As described by Walter Bortz, a physician who teaches medicine at Stanford University, dying takes too long and it costs too much. Because it takes too long, excess pain and suffering are created around an already difficult and often tragic set of circumstances. It can take too long because patient wishes to avoid extraordinary or heroic measures are unknown, unsolicited, or disregarded. Providers feel morally and legally obliged to do everything to delay death, and dying may take too long in human time when effective pain control measures are withheld and appropriate psychological support is unavailable. If death is inevitable for a patient, suffering and spending should not be maximized if the patient does not desire it. Technically, according to Oxford University's book, Healthcare Law, a patient can refuse life-sustaining treatment at any time, and doctors are legally obliged to respect this choice. This means that doctors are already allowed to let patients die with request and consent of the patient, as long as they are not actively causing the patient's death. This is often referred to as passive euthanasia, a form of which would be hospice care. Still, it is important to note that there is a difference between euthanasia and physician-assisted suicide. With euthanasia, the doctor injects the lethal substance themselves, while with PAS, the patient is supplied the lethal means and gets to choose who gives the injection, when, and where. This is much easier for physicians since there is no guilt involved and patients can back out at any time, yet the logic is still the same. If doctors are allowed to passively let a patient die by request, it does not make sense to not allow doctors to play an active role through a prescription. Doing so would eliminate a great deal of suffering for patients, since death through passive euthanasia causes patients to endure pain and a loss of dignity. While some may argue that terminal patients' pain is manageable, according to Ann Hansen, an experienced writer, only 700 out of 4,000 American hospitals offered palliative care programs. Palliative care is a pain management program for terminally ill patients. This means that 83% of patients cannot easily access pain management, which is unacceptable. Patients should not be in pain if there is another alternative. Another common argument against physician-assisted suicide is the slippery slope. Many individuals and sources claim that in countries where the act has already been legalized, there has been a dangerous impact on patients and that individuals are being killed without giving consent. However, this is misinformation. The survey generally used to support the slippery slope argument is a 1990 study known as the Remelink Report. This survey claims that doctors killed over 1,000 in the Netherlands without their direct request using euthanasia since its legalization. Yet, the report does not make a distinction of whether this statistic is higher than the amount of involuntary deaths before the legalization of physician-assisted suicide. As Penny Lewis, a mathematician and medical ethicist from MIT, describes, the critics who rely on this slippery slope argument often omit two important elements, thereby using flawed logic. First, the argument is only effective against legalization if it is the legalization which causes the slippery slope. Second, it is only effective if it is used comparatively to show that the slope is more slippery in the Netherlands than it is in jurisdictions which have not legalized assisted suicide or euthanasia. This means that even before the legalization of assisted suicide, patients were killed without giving explicit consent through underground euthanasia. Unless there is a direct correlation between the legalization and an increase in undesired deaths, there is no reason to believe in a slippery slope. In fact, there is no evidence to show an increase in undesired deaths in the Netherlands since legalization. Regarding the Netherlands' legalization of physician-assisted suicide in 2001, Dutch surveys of 1990, 1995, and 2001 reveal that the rate of non-voluntary euthanasia, or ending of life without explicit request, has remained stable since 1990 at 0.8% of all deaths in 1990 and 0.7% of all deaths in 1995 and 2001. This shows that the legalization is not the cause of any unsolicited deaths through assisted suicide. In addition, rates of ending life without patients' explicit request in many countries where physician-assisted suicide is illegal is actually higher than that of the Netherlands post-legalization. In Australia, Denmark, and Belgium pre-legalization, the rates were 1.5%, 0.67%, and 1.5% respectively versus the Netherlands' 0.6%. So, not only is there no correlation between the legalization of PAS and involuntary deaths, but the rate of unwarranted deaths from PAS are actually higher in countries where the process is illegal. If a slippery slope is possible, therefore regulation of assisted suicide must not be adequate, yet this is also not the case. In countries where the process is legal, strict guidelines have been put in place. In the Netherlands and Belgium, a doctor can only proceed when they know the patient is well enough to be able to assess whether their request for euthanasia is voluntary and well considered, whether the patient's medical situation is without prospect of improvement, and whether the individual's suffering is unbearable. The ability to refuse a request for euthanasia guarantees a doctor's freedom of conscience in both countries. The process of physician-assisted suicide is extremely well thought out. Not only is the process entirely optional for the patient, but no doctors are forced to perform assisted suicide if they do not desire. Some argue that the law would be expanded and that those with mental illnesses and clinical depression might be able to request to be euthanized. However, legalization in other countries show no evidence for this. Medical professionals are required to ensure that patients are not mentally ill before fulfilling their desire for assisted suicide. As described in the Journal of Law, Medicine, and Ethics, the most important safeguard is consultation with an independent physician skilled in palliative care who is responsible for determining that all policy criteria and requirements have been satisfied. Among other things, the consultant would verify that the patient is terminally ill and mentally competent, and that the request for a hastened death is not driven by a treatable depression, inadequate pain relief, or a lack of support. This means that physician-assisted suicide would only be available for those who are terminally ill with few months to live and likely poor quality of life. With these regulations, it is highly unlikely that individuals will be killed without consent or non-terminal patients will be allowed to pursue assisted suicide unless, of course, they do so illegally, which is already occurring. In order to reduce the pain and suffering of dying patients, assisted suicide needs to be legalized. Contrary to popular belief, it has already been proven that the regulation of PAS is possible, and there is no evidence that its legalization leads to a slippery slope. It is immoral to leave a dying patient suffering when they desire to pursue another alternative. Americans are owed the right to live and die in their own fashion.